Okay. Hi, everyone. Welcome to the second measles talk. So if you still want that post-lunch nap, now's a great time. I'm David Sinclair. I'm a postdoc in the Public Health Dynamics Lab at the University of Pittsburgh, although from September I'll be moving to Newcastle University in the UK. And I'm going to talk about some simulations that we've been developing on forecasting the size of potential measles outbreaks in the US in the state of Texas. And this is work I've been doing with my collaborators at the University of Pittsburgh and the Texas Pediatric Society. I'll start off with a brief reminder of what measles is and what the context of measles is in the United States at the moment. I'll go over agent-based models, what they are and why we decided to use them. Then I'll kind of talk about our specific Texas measles simulations, talk about the results that we've been getting, and then conclude. So measles, as we just heard, is a highly contagious infectious disease, basic reproduction number of 12 to 18, so in an entirely susceptible population. If you plonk somebody down with measles, they will on average infect 12 to 18 other people by the time they recover themselves. So you can see how very quickly measles can spread in a susceptible population. And it's got some severe complications. One of the most common ones is pneumonia, but there can also be brain damage, hearing loss, and death. About 1 in 2,000 cases, at least in the US, kind of ultimately end up in death. Fortunately, though, as we've just been hearing, there's an effective vaccine. The MMR vaccine stands for measles, mumps, and rubella. If you have one dose, then that confers immunity to about 93% of people. And 2 doses confers immunity to about 97% of people, and 2 doses is the recommended dose. And the measles vaccine has been very successful in the US. So this is a plot of the number of cases of measles in the US from the 1950s through to 2008. You can see early on in the 50s, there were hundreds of thousands of reported cases. In reality, there were probably a lot more because they weren't all reported. And then the first red line on the left shows when the measles vaccine was first introduced in 1963. Very, very quickly, the number of cases tails off to being in the tens of thousands. And it continues to reduce until the year 2000, where, as we heard in the last talk, measles was declared eliminated in the United States, where eliminated means no continuous transmission within the country for a period of 12 months or more. So a great success story for vaccination, a country that's getting hundreds of thousands of cases, going down to tens or hundreds a year, all through vaccination. Unfortunately, measles is resurgent in the US as in other parts of the world at the moment. And we've gone from being in a situation where, maybe in 2010, there was only 63 cases in the entire United States for a population of 330 million people, through to this current year, where up until last Monday, there are 1,077 reported cases. There'll be new numbers out today. We might be over 1,100 cases, and that's just for half the year. So by the end of the year, if it keeps going at this rate, there may be somebody who dies from measles in the United States, which for a disease that was declared eliminated 20 years ago would be pretty disappointing from a public health perspective. Just for some context, India had about 47,000 cases of measles from May 2018 through April 2019, for a population that's about 4 times greater than the United States. So vaccination levels in measles are not where they are in the United States, in India, but United States is showing, at least, if you do vaccinate people, it can be quite successful, as long as you keep them vaccinated. And there are various reasons why measles seems to be resurgent related to vaccination requirements, as we've just been hearing. And in the United States, every student who attends school is required to either be vaccinated against measles along with various other diseases, or they're required to have an exemption to vaccination. And these exemptions take 3 different forms. Medical exemptions, so if you have a weak immune system, you're not required to get vaccinated. Or maybe in rare cases, if you've already had measles, you have immunity that way, so you don't need to get a vaccination. But there's also these personal and religious exemptions, which are basically grouped as non-medical reasons for refusing a vaccine. And these personal and religious exemptions are available in 45 out of the 50 states in the United States. Until this past year, they were available in 47 states. So widely available, pretty much available on demand. You just request it. There are various kind of religious groups associated with lower vaccine uptake, but the ones where there's been more kind of measles cases in recent years, such as in Brooklyn at the moment, there's an outbreak associated with the Jewish community there. In Ohio a few years ago, there was an outbreak associated with the Amish community there. But by and large, none of the major religions in the US actually require foregoing vaccination, as far as I'm aware. I'm not a theologian, so theologians may disagree. So you can kind of group these as, these are ultimately personal decisions or decisions made by small cultural groups within kind of wider communities. And there are different reasons why people kind of want these non-medical vaccine exemptions. As we've just been talking about, there's concerns of potential side effects. So you've probably all heard of the paper that was in The Lancet about 20 years ago that found an association between the MMR vaccine and autism. That's been thoroughly discredited since. But there's still a kind of fear that remains among people that there are potential side effects to the vaccine. Also fear of actual or perceived ingredients in the vaccine that could be harmful to people. The fact that measles has been relatively rare in the United States for a long time now means people don't perceive it themselves to be susceptible to it, and they don't perceive it to be a severe illness if people get it. People say, well, it used to be very common, it used to be everybody got it, and it was just a rash and then it went away. And people kind of, for whatever reason, don't think about the actual side effects, complications associated with measles and the potential consequences. And there's also social influences. So there's some studies that have found if parents of children who know parents who have decided not to vaccinate their children are more likely themselves not to vaccinate their own children. And this is especially problematic because you can then lead to this kind of networks where you have people who are happy to be vaccinated and people who are unhappy to be vaccinated. And you don't have homogeneous mixing amongst the population. You have this kind of clustering over space and through social networks where people who are unvaccinated are far more likely to be interacting with other people who are unvaccinated, whether this be in schools with low vaccination rates or within other community groups. And this makes it much easier for measles to spread amongst the people who are not vaccinated because the benefit of herd immunity is lost because you don't have the kind of barriers between people of the vaccinated people. And so within this context, we decided to do some simulations. We were actually asked by the Texas Pediatric Society if we could come up with some forecasts for what could be the size of potential measles outbreaks in Texas. And Texas is especially interesting in the United States for a few reasons. One is that it's the second largest state in the United States by area and population. That's about 29 million people. And it is the largest state that allows non-medical exemptions to vaccination. California is larger, but in 2015, they got rid of non-medical exemptions, at least in theory, after they had an outbreak in Disneyland. And so Texas, very large state. It's home to the 4th and 5th largest metropolitan areas in the country, Dallas and Houston. And it's also, there's a lot of debate going on there at the moment and a lot of lobbying, both in favor and against various vaccine and vaccine exemption policies. And because of the kind of size of Texas, it's got a lot of different sizes of metropolitan areas that kind of are representative of a lot of metropolitan areas across the entire United States, from the smallest metro areas with a few 100,000 people to the largest with, millions of people. So we figure it's a good example of looking at the wider United States in general. And unfortunately, non-medical exemptions among school children in Texas have been increasing. So this is a plot of the number of non-medical exemptions amongst all the children in Texas schools from 2003, when the law changed to make it easier to get non-medical exemptions, through to 2016. And it's gone from about 2,000 odd medical exemptions in the entire state through to 45,000 on this plot. In fact, if you look at the latest figures from this past academic year, it's continued. It's now at 64,000 non-medical exemptions. So that's 64,000 children in schools in Texas who are not vaccinated for non-medical reasons. And it's just growing every year. So what's going to happen at the current vaccination rates and with this kind of clustering in certain schools of non-medical exemptions, and what's going to happen if it keeps these non-medical exemptions keep on rising and follow this trend. And as I said, there's a lot of debate going on in Texas at the moment about what to do about this and what kind of laws to potentially change or not change related to vaccine exemptions. One of the things that's trying to be pushed for by people in favor of vaccinations at the moment is just a relatively simple thing in that schools are required to publish their vaccination rates in the US. That's a federal law, but quite how it's done depends on the state. And in Texas, all the public schools, so that's the schools that are provided by the government for free to the people, publish their vaccination rates on a district level. So if you have 1 or 2 schools in a district that have a low vaccination rate and every other school has a high vaccination rate, you don't necessarily become aware of the fact that there's these pockets of low vaccination rates that are more susceptible to measles spreading there. And 2 bills were introduced to the kind of state Congress this past legislative session in the spring, trying to get this changed, but I don't think they went anywhere. And interestingly, these 2 bills were both from the 2 main parties. This is not a partisan issue in Texas, but Republicans and Democrats, the 2 main parties, both had people trying to change this law. But on the other side, there's a strong and well-organized anti-vaccine lobby in Texas. And the last state representative, state legislator, who tried to change this exact policy a few years ago, was ultimately deselected by his own party and voted out in favor of another candidate in a kind of victory claimed by the anti-vaccine lobby in kind of changing the candidate because they didn't like somebody who was trying to change these vaccine laws. And the fear from the anti-vaccination lobby is that if you start publishing individual schools data, that will make the children who are unvaccinated more identifiable within these schools. And they don't want their children at risk of being discriminated against because people become aware of this. Whether or not that would be the case is debatable. It's simply a number that published in terms of vaccination rate. It's not identifiable, but this is the argument. So that's the background for measles and specifically in Texas. We tried to understand what might happen in measles outbreaks in Texas using agent-based models. So we've heard a little bit about agent-based models already today, and what they are. Agent-based models are also sometimes called individual-based models, are a kind of class of simulation models that ultimately comprise a collection of agents. And agents can represent individuals, they could be people, they could be animals, they could be cells, and these agents follow rules. And so these are typically relatively simple rules. So in our simulations, we use people, and we have rules such as, people start the day in their household with their families. Then if they're representing an agent representing a child, they'll go to their school. And then they interact with other agents representing children in their school. And then at the end of the day, they come back home. Whereas adults, if they're employed, will go to the workplace and come back home. And crucially, this agent behavior can adapt as the simulation is progressing. So, if an agent becomes infected with a disease, they can change their mind about going to school or work on that day and decide, actually, I'm going to stay home today because I'm not feeling very well. Or, as we've just been hearing, they might decide, oh, vaccination sounds like a good idea. Maybe I should do that. And then you can kind of put these individual agents and their interactions with one another and their behavior and how that changes on like an individualized basis and kind of collate that across an entire population to try and understand how the kind of population level behavior and interactions can affect, in this instance, how an infectious disease spreads amongst the population. And there are various advantages to using agent-based modeling as a technique. You have heterogeneous agents, so you don't have to kind of group people together into compartments. You don't have to assume homogeneous mixing amongst people. The agents have memory, so you can specifically keep track of which agents have been vaccinated, which agents are ill. There's no aggregation there. And you can include in explicit spatial dependence. So if you want to have behavior changing as a function of how close people are to being infected, where the prevalence of diseases, that's produced in hearing, that's very easy to kind of encode into an agent-based model. But there are also disadvantages. These can be quite complicated models with lots of parameters, and therefore you have to parameterize that. They can be computationally intense. Texas has 29 million people. If you're trying to keep track of 29 million people and how they're interacting and what they're doing on a daily basis, that can demand quite a lot of computational resources very quickly. And there's a learning curve associated with creating and building your own agent-based models. So what we do at the University of Pittsburgh Public Health Dynamics Lab is we use a tool called FRED, which we developed in-house. It stands for the Framework for Reconstructing Epidemiological Dynamics. And it's a tool we've made for doing kind of epidemiologically based agent-based models. And there's various key concepts we have in FRED. So we have our agents, which represent individual people. It has both space and time. So in the US, we have a three-dimensional geography of the entire country. We have a longitude and latitude for everyone, and an altitude associated with every place, where altitude can be important, especially for mosquito-borne illnesses or pollution simulations. We have time, so we can, agents do different things throughout the day, and we can change their behavior or encode their behavior on an hourly basis or day basis and run simulations for, years if we want to. We have various mixing places. So by default, we have all the households in the US, neighborhoods, workplaces, and all the schools in the US. So every single school in the United States, at least the schools on government records, we have an in silico version of that score in our model in the same location with the same enrollment size as the reported data. And so we can say, given where people are living, we can assign agents to different schools, because people tend to go to schools near to where they live. And we can take census data that says how many people are living in different places, what's the demographic breakdown of the people living in these places, to populate our agents and give them their characteristics. So if you take a census block, which is, basically a couple of streets in the United States, you'll have data that's published saying, how many people there are male or female, what's the age distribution, what's the race distribution, what's the household income distribution, and along all these kind of demographic axes, we kind of are statistically representative down at this kind of census block level in our synthetic population. And kind of on any given day, by default, if we want to run our simulations, our agents will say start in their households with the agents representing their family members. And let's say, this agent in red is infectious with flu or something. They start simulation day. The agents representing school children go and interact with each other in a school. The agents representing workers go to workplace. Agents are interacting. Maybe one of them sneezes on another one, transmits flu to them. They then go back home, and then they're interacting with their families again, and maybe they pass on the infection to their family members. And we can keep iterating like this for however long we want, and kind of track how an infectious disease will spread amongst the entire population. But like I said, there's agent-based modeling, especially this kind of stuff, has a learning curve associated, has computing resources. So advertisement for next week. We developed FredWeb, which is an online platform for creating, running, and analyzing agent-based models. We've got a graphical user interface to try and facilitate simple model development and make it a bit easier for people when they start. We have our own server that we've got dedicated on the back end, so you don't need to provide your own computing cluster to run these simulations. And we've kind of included some simple plotting and mapping tools there for some basic analysis. I'll be running a workshop on this next week to give you a chance to try out FredWeb and see the kind of things Fred can do. But back to our Texas measles simulations. So we have Fred. We have what we believe is a reasonably good representation of the entire US population. So we've got Texas included in that. We have the schools, we have the households, we have where people are mixing to some kind of reasonable level, we assume. So if we're going to track how measles is going to spread amongst this population, we need to know who's vaccinated and who's not. And as I was saying before, the school vaccination rates are published. And they're published at a district level for the public schools, but we still have some information there about what the vaccination rates in schools are. Private schools are published on an individual level, so we've got much better information about those schools, which is particularly useful because people who are more likely to be associated with non-medical exemptions for philosophical reasons or religious reasons are the more likely ones to attend a private school. Every religious school in the US is a private school, and so if based on a religious reason or certain philosophies of teaching, like the Waldorf schools, are kind of the classic ones cited in kind of low vaccination rates, they're private schools, so we know their exact vaccination rates. Or at least we know what they tell the Texas government on a survey they're meant to fill out every year. We can say every agent over the age of 62 is immune to measles, and that's because those agents are representing people born before 1957, when measles was widespread in the US. So the CDC, Centers for Disease Control and Prevention, assume that anyone over the age of 62 is immune to measles because they've almost certainly had measles when they were a child. And for the rest of the population, we used some study on kind of seroprevalence analysis, so looking at measles antibodies in people's blood samples, and that shows that about 95% of the US population has measles antibodies, and who are like not school age and not over the age of 62. So we take that to mean if you've got measles antibodies, then hopefully you're immune. So we put that data into our population. Instantly, we also have homeschooled students in our simulations. About 2% of our students in the US are homeschooled. We don't have any specific vaccination data for them. That's not reported anywhere. So we assume that they are vaccinated in line with the background population. That could be right, could be wrong. There's no particular incentive to homeschool your child if you're against vaccinations, because you can just request a non-medical exemption. So that doesn't necessarily bias the sample that way. And either way, it's a small fraction of the children who are homeschooled, so they're not interacting with as many other children as children who go to school. So they're hopefully a relatively small effect in the size of the measles outbreak either way, provided they have a reasonable vaccination level. So we put all that data in. As I said, we have every school in the US in our model. Incidentally, I should have said this earlier, we also have a synthetic population for Telangana state in India, where Hyderabad is. But most of the simulation we do with our US data. And so, we have our school districts, and we can say, okay, we know the average vaccination rate in the school district is, say, 97%. So for the sake of our model, we just assume all the schools are vaccinated at the same rate. So that is almost certainly not correct, but, when people attempt to get the law changed to make that data more accessible, they lose their jobs. So, what can you do? And the private schools are reported individually. By the way, this is purely illustrative. These schools are not in school districts together. These are not the vaccination rates of these schools. I don't know. I've got the data for it, but I just put this together as a mock-up. So don't be worried if you happen to have a kid at Rosemont Elementary School. They're not as much risk as the data might suggest. But we don't have the data for every school. So despite the fact that there was a law in Texas saying every school has to report their vaccination rates, not every school does. We're missing data for about 5%. There's a law in place, but there's nothing to actually enforce that law, which is, again, another problem that might be debated in the Texas state legislature about how to potentially deal with this vaccination problem. So to kind of estimate the vaccination rate of the schools we don't have, what we did is take the data of schools nearby, so of the same type. So if we don't have the information for a private school, we look at the other private schools in that metropolitan area and say, okay, what are their vaccination rates? We fit a kernel density estimate to all the vaccination rates of those schools, which is just a non-parametric way of getting a probability density function. And then we can draw samples from that kernel density estimate to kind of come up with estimates for the vaccination rates of the schools we don't have information for. And then we need a measles model. So the Centers for Disease Control publish a kind of useful book called the Pink Book on all different infectious diseases. And within the Pink Book, it tells clinicians these are the stages of the infectious diseases and what's different about the different stages. And it recognizes kind of 5 key steps within a measles infection that are kind of broadly there in every infection. So we assume our agents who are not vaccinated start off as susceptible. If they get exposed, they'll be in this exposure state where for about 11 or 12 days, they are kind of incubating measles, but they have no symptoms and they're not infectious themselves. After this period, there'll be about a day or so where they're latent, so they are now infectious. They can pass on measles to other people, but they won't necessarily show any symptoms, or if they do, they might not realize they have them because they're very minor symptoms. That's followed by 3 days roughly in a fever state, 4 days of the kind of classic measles rash that most people are aware of, and then 10 days of recovery followed by a lifetime of immunity. And we've kind of made some assumptions in this model where we say, okay, people are infectious in the latent fever and rash stage, but we'll assume that when people are in the fever stage, they have a 50% chance of confining themselves to their households. Key things to remember in the US, unlike pretty much every other kind of major Western industrialized country, there's no such thing as guaranteed paid sick leave. So if somebody's ill in the US, they need to choose to take a holiday day. If they're, depending on their job, they may have to choose to take a holiday day, not get paid that day, or go to work and risk infecting their co-workers. And the US, in its political wisdom, has decided that that is a good decision to leave up to everybody by not giving them, paid sick days. So we'd say, there's a chance of people going to work when they're ill or sending their kids to school when they're ill because you think, oh, it's a fever, it might not be that bad, and they don't want to miss getting paid or miss one of their precious holiday days. And then in the rash stage, we figure most people will recognize that for what it is, or people will get a diagnosis fairly quickly. So we assume 95% of people in the rash stage stay entirely confined to their household to make it harder for them to transmit to other people outside of their family. And so we run our simulations. In each of our simulations, we randomly infect 1 people who a vaccine has been refused for at the start of the simulation, and then we run it, run all the interaction with the agents for 9 simulated months. 9 months is useful because that's about the length of the school year in America. And the kind of daily interactions between school pupils changes radically over the summer because they're no longer going to school. We don't model any interventions. So we're just purely saying, what happens if the government or the state government just kind of sits back and says, okay, we're going to accept the kind of vaccination rates as they are. And if we assume that we're not kind of spending a lot of money to try and intervene with an outbreak once it happens, what's the worst case scenario that can happen? Like, for context, there was an outbreak in Washington State earlier this year where about 70 people got infected. The county where that mainly happened spent 10% of their entire public health budget for the year on that one outbreak of 70 people. So these interventions are not cheap. We simulated each metropolitan area in Texas individually. So metropolitan areas, these are defined by the Census Bureau, and basically the areas where there's far more internal interaction between people through commuting and kind of daily interactions than there are kind of with outside environments. So we don't simulate explicit transmissions between these metropolitan areas, we just focus on each one in turn. And then we simulate the current reported vaccination rates and then future potentially decreased vaccination rates if we're saying, well, this trend of non-medical exemptions is going up every year, so how is this going to change potentially in the coming years? And our results. So hopefully, my remote control will work. So these are some of the simulation, just an example of the kind of things we get out of Fred. So these are animations of kind of simulated measles outbreaks in Austin, which is a major city in Texas. Each red dot is a measles case. On the left, we have a simulated outbreak at current vaccination rates. And on the right, we have a simulated outbreak at absolute 5% decrease in vaccination rates. I know it says 10% there, but it should be 5%. And so we can see, at current vaccination rates, maybe 24 cases of measles. That's not great. That would be the second largest outbreak in Texas since measles was declared eliminated. But if you continue to drop these vaccination rates very, very quickly, you're getting, thousands and tens of thousands of cases. So if we kind of plot that in a box and whisker style diagram, we can say, okay, at the current vaccination rates and decreasing vaccination rates, what's the kind of distribution of the kind of number of measles cases that happen in different simulations? So these simulations are highly stochastic. We only see them with one individual case each time, which is kind of typically of what will happen in the United States, in that someone will travel either who lives in an area abroad and then come back with measles, or somebody will visit there from another country who's got measles and start off an outbreak from just one case. And so, we have these distributions. And so the kind of top whisker is showing the kind of 95th percentile. So this is kind of a plausible worst case scenario. 1 in 10, 20 measles outbreaks might be this bad. And kind of the middle bar is showing us the median number of cases. So we can see this is Houston, another major city in Texas. At the moment, it's not terrible. There might be 20 odd cases of measles if in a kind of worst case scenario, and maybe 2 in a kind of the most likely scenario. But as your vaccination rates decreases, the worst case scenario kind of exponentially gets worse. And we also, because we have the agents and we know which agents are vaccinated, which agents have chosen to refuse vaccination, which agents represent those who have non-medical exemptions, so it's not their choice not to be vaccinated. We also know the agents who the vaccination failed for them, so 3% of people who get vaccinated don't have any immunity. And we also have the kind of background adult population who are unvaccinated for whatever reason. And we can say, well, people are choosing to seek out these non-medical exemptions, but 36% of the cases in the larger outbreaks we're seeing, so more than 25 cases across Texas, more than a third of cases are infecting these people who aren't in a situation where, as a child, there's a decision being made for that. And so, it kind of affects the debate here of kind of individual freedoms and, the ability to decide whether to get vaccinated or not, which is culturally very, individual freedoms in general are very important in America and especially Texas. Against a wider kind of population public health benefit of, making it difficult to avoid vaccination if you don't have a good kind of medical reason to avoid vaccination. Is this going to move? Sorry, it's being a bit slow. Whilst this one is up, okay, so this is just a map of Texas. These are the metropolitan areas that we kind of simulated. Kind of each metropolitan area has got this kind of black border around it. The white borders are individual counties in the state. And so you can see, at current vaccination levels, a kind of a plausible worst case scenario, 1 in 20 outbreaks, you might be getting more than 100 cases of measles in some of the major cities, so Dallas and Austin. Austin is, a kind of center of the anti-vaccine movement in Texas and the US. It's actually where the person who proposed the link between the MMR vaccine and autism currently lives, and so it's kind of a focal point for the anti-vaccine movement. But if you let the vaccination rates continue to get worse, you're seeing, in the major cities, more than 500 cases, potentially thousands of cases in a measles outbreak, and kind of pretty much everywhere you're seeing, of order 100 cases at least. And if we plot all the metropolitan areas here, this is probably difficult to read, but each plot is showing a different metropolitan area in Texas. And there's a green line showing the kind of total kind of expected number of cases in a worst case scenario. And the red line is showing the kind of expected number of cases in the bystanders, so not the people who have the non-medical exemptions. And in both cases, in all these different areas, we're seeing our forecasts showing the kind of number of cases are going up exponentially as the vaccination rates decrease. So what are the kind of broad conclusions we can draw from these kind of forecasts? One is that geographic clustering is very important, which is kind of well recognized. in general, but we can look at the metropolitan area of Tyler, which is relatively small. It's about 200,000 people. It's in northeast Texas, east of Dallas here. And our forecasts predict that they could have outbreaks of order 100 cases at the moment. So this would be, the second largest case outbreak of measles in the United States since elimination before this year. At the moment, there's currently a couple of large outbreaks going on in New York, which are bigger than this, but up until they happened, 100 cases would have been kind of extremely rare. And why is this small city with only 200,000 people so much at risk? Well, there's two high schools there with one's got a 70% vaccination rate, one's got an 85% vaccination rate. So you put, all these kids who are in these schools easily infect one another, and despite the fact that there aren't people, you very quickly can have a large outbreak. We also are seeing that, okay, we're showing, there might be bad worst case scenarios, but typically most outbreaks are only going to have 1 or 2 cases, and that's not so bad. Herd immunity is doing its job in, stopping the infection spreading too widely. And that's kind of consistent with the data for Texas in terms of the number of cases over the past decade or so. So it's like, between 1 and 6 cases, 1 and 10 cases each year in the state, and this could be over 2 or 3 separate individual outbreaks. But this can potentially lead to complacency. People saying, "Oh, we're having measles outbreaks, but they get contained. We don't need to worry about potential worse effects." But that's exactly what our simulations would expect to happen, and there still remains the chance that you can have these kind of larger outbreaks, potentially like in 2013, where 27 people got infected. And I think what's probably the most valuable thing about these kind of forecasts is that we can start personalizing the risk to people. So, it's well established that vaccines work and they're safe. People know this, but vaccine hesitancy is still growing. So how do we convince people that maybe they should get vaccinated? And doing these kind of agent-based models where we can say, well, look, we're simulating your town, we're simulating the school you send your kid to with the data that we know about that school, and this is what can happen there. That can hopefully, get over those kind of low perceptions of severity of measles and low perceptions of susceptibility by saying, this is the risk to you right now, and this is the risk as to what will happen in the future. And we've had some success with this. So a few years ago, we did some kind of simple simulations, just doing uniform vaccination rates, and put them on our website for different metropolitan areas across the country, across the US. And then Disneyland in California had a measles outbreak that infected about 60 or so people. And then California thought maybe we should change our non-medical exemption laws. And ultimately they voted it through. But the kind of person leading the kind of vote and trying to get the vote law changed was Senator Pyne, who's actually a University of Pittsburgh alumni. And he went on our website and saw our simulations and then started showing them to all his colleagues in the state Senate and saying, look, this is the town or the city that you represent, and this is what can happen in a measles outbreak in your town. And it's kind of on the record that at least one senator changed his mind and decided to vote in favor of changing the law to make non-medical exemptions harder to get because of these simulations. So, that's one little bit of progress that, helped change a law, but in the big state. And, this law may have changed anyway. I'm not saying that this is responsible for passing the vote, but it's a good sign that this can kind of bring home the risk of measles and make it a bit less abstract to people and a bit more real. Okay, so in conclusion, our forecasts are showing that there might be hundreds of cases at current vaccination rates in some metropolitan areas in Texas right now, that this will just get worse if the vaccination rates continue to decrease. It's, a fair chunk of the people getting infected are not the people who have these non-medical exemptions, and personalizing the risks and hopefully reduce vaccine hesitancy. Thanks.